For joining our webinar today. This is our second webinar for 2020. My name is Ashraf Gorgi. I'm the director of the Spinal Cord Injury Research at the McGuire VA Hospital, as well as professor of physical medicine and rehab at Virginia Commonwealth University. Also, I'm the chair of the FES task force FES and Technology Task Force hosted by American Congress of Rehab Medicine. So today we have the pleasure to introduce our guest speaker, Dr. Carrie Peterson. The title of her talk will be Upper Limb Rehabilitation After Cervical Spinal Cord Injury. Dr. Peterson, she's a faculty at Virginia Commonwealth University. She received her master and PhD degree in mechanical engineering from the University of Texas at Austin. She's then completed her postdoctoral training at Rehab Institute of Chicago. She's currently an assistant professor in the Department of Biomedical Engineering at Virginia Commonwealth University. Her research focuses on non-invasive neuromodulation techniques and modeling and stimulation of human movement. Her lab's current research projects include using transcranial magnetic stimulation to measure and direct neuroplasticity and forward dynamic analysis of wheelchair propulsion to better understand mechanism of shoulder pain in wheelchair users. Some home take message for us. We are going to have the speakers speak for 45 minutes, and then we have the last 15 minutes directed to question. So if you have any question, please feel free to type it on the chat screen so we can just pass it to everyone. On top of this, Dr. Peterson, when she finished her presentation, this presentation will be recorded and will post it on ACRM website. So if you have missed the opportunity to have access to the presentation, you can go back and access the presentation. Again, I'm going to ask all of you to mute your background and mute your microphone, and we'll give the option for Dr. Peterson to share her screen with us. So Dr. Peterson, go ahead. Dr. Peterson?
Yeah. Can you hear me? And am I sharing the screen? All right. I'm going to assume that it's fine. Okay, Jenny, thanks. Somebody responded. I don't think Ashraf can actually hear me is the problem. Okay, well, thanks for the introduction and the opportunity to present today. Yeah, some of the title of my talk is Upper Limb Rehabilitation After Cervical Spinal Cord Injury. And you just learned about my background. I'm now an assistant professor of biomedical engineering at VCU. And let's see. So here's the learning objectives for this presentation. I did myself a favor and created quite broad learning objectives. Within these objectives, I'll focus on my own research experiences, but the objectives are to describe current rehab approaches to improve upper limb function in individuals with cervical spinal cord injury. Also to discuss promising strategies to preserve and restore upper limb function, and explain how neuromodulation techniques may be beneficial towards optimizing rehabilitation outcomes. So why is upper limb rehabilitation for individuals with spinal cord injury important? Well, spinal cord injury can result in complete or partial paralysis of the upper limbs depending on the level and completeness of the lesion. Tetraplegia following damage to the cervical spinal cord is the most common neurological classification after spinal cord injury. The level of injury plays an important role in determining the outcomes of functional recovery. But generally speaking, tetraplegia results in impaired upper limb function, which can include deficits in motor, sensory, and autonomic function, as well as pain. And the upper limbs are involved in many self-care tasks required for independent living, such as eating, dressing, using technology and computers. Further, because of paralysis affecting the lower limbs, individuals with tetraplegia use their upper limbs for mobility. So transferring into out of the wheelchair, also for propelling the wheelchair. Therefore, improved upper limb function is the most desired outcome of individuals with cervical spinal cord injury following rehabilitation. Within the learning objective to describe current rehab approaches to improve upper limb function in individuals with cervical SCI, I could touch on all of these different strategies. However, I'm going to focus on my own research experiences. I do want to note that a very good summary of all these technologies or approaches are provided in the Upper Limb Rehab Following Spinal Cord Injury publication by the Spinal Cord Injury Rehab Evidence Group. So based on my experiences and research, I'm going to focus on surgical interventions as well as non-invasive brain stimulation. And also I will touch on modeling and simulation approaches that can inform rehab strategies with attention to therapy-based surgical interventions and non-invasive brain stimulation. So my presentation roadmap follows my trajectory in spinal cord injury research. As a postdoc at the Rehab Institute of Chicago, I led a study focused on tendon transfers that led to further research in non-invasive brain stimulation and computational modeling. So I've created a roadmap following the trajectory of my research. So starting with tendon transfer. There's various types of reconstructive surgeries that are performed to increase upper limb function in individuals with spinal cord injury. These surgeries involve transferring a tendon to restore lost function. For example, in the figure here, the non-paralyzed brachioradialis can be transferred to the flexor pollicis longus to restore pinch function. The type of reconstruction performed depends on what muscles and tendons are present and if they are strong enough to be transferred. And functionally, there's several benefits to tendon transfer. But these surgeries do remain underutilized. For those who do choose to undergo tendon transfer surgery, satisfaction is high, with roughly about 75% of patients reporting satisfaction and improved performance of activities of daily living. Considering this webinar series involves attention to functional electrical stimulation, I did want to point out, if you only care about FES, there is evidence that FES is a beneficial training method when paired with surgical interventions, and here's an example publication that you can read for more information there. Elbow extension in particular is needed for many activities of daily living, in particular for locating the hand in space, propelling a wheelchair, performing weight relief lifts. And therefore, tendon transfers have been developed to restore that lost elbow extension function after cervical spinal cord injury. Either the posterior deltoid or the biceps can be transferred to restore elbow extension. When the deltoid is transferred, an interposition graft is used to connect the posterior deltoid to insert on the tip of the olecranon, thereby changing the deltoid into an elbow extensor. And then when the biceps is transferred, the biceps tendon is cut and then transferred medially around the humerus and inserted within the tip of the olecranon, thereby turning the biceps into an elbow extensor. Typical post-surgery rehabilitation following tendon transfer consists of wearing a cast for 4 to 6 weeks in full extension, and then that cast is exchanged for an elbow brace with an adjustable range of motion. Elbow flexion is increased by increments of 10 to 15 degrees per week during the mobilization phase. And then that's followed by light strengthening and functional training in the final weeks of rehabilitation. So that's the conventional therapy after elbow extension tendon transfer. So the goal of our previous research was to compare the deltoid to triceps and biceps to triceps transfers with regard to 3 important measures that hadn't been quantified before, being maximum isometric elbow extensor moments, maximum voluntary activation of the transferred muscle, and corticomotor excitability of the transferred muscle. And I'll explain that last term in a couple slides, so just hold on for a second. The significance was to form whether one of the tendon transfers was advantageous over the other, and also to inform whether rehabilitation or re-educating the muscle to perform a new function, that is elbow extension, whether that motor re-education does promote complete ability to voluntarily activate the transferred muscle in elbow extension. So the methods in the study were we recruited individuals with either deltoid or biceps transfer. Sorry, I'm a little distracted. I'm seeing some chats that some people can't see my slides. Okay, hopefully that's not everybody. All right, so recruiting, again, these surgeries are underutilized, so recruitment, we tried pretty hard, but we were only to successfully enroll 6 arms with deltoid transfer and 7 arms with biceps transfer. We tested these individuals in 3 isometric functional postures, shown here. So a posture in the horizontal plane, a posture in a pressure relief or weight relief position, and a posture in overhead reaching. The protocol was in each of these postures, we recorded 3 maximum isometric contractions and elbow extension. And the participants also completed a series of moment matching trials with electrical stimulation superimposed. And that was done to assess voluntary activation of the transferred muscle. Voluntary activation was measured via the interpolated twitch technique. That involves stimulating the transferred muscle at various levels of voluntary effort, including maximum. And we then detect differences, if they're there, between the maximum moment that the individual can generate voluntarily versus the moment generated when the electrical induced recruitment of muscle is superimposed on top of the voluntary contraction. So here's just a quick video. We'll see if this plays, yeah. Showing one of those moment matching trials. So this is submaximal, but the subject is provided feedback. We have this elbow moment transducer that's recording the elbow extension moment, and the participant matches that moment and a stimulus is delivered to the transferred muscle. So just to show you what the interpolated twitch data looks like. So here's a plot of the elbow extensor moment on the y-axis relative to time. So the stimulus is delivered at time 0. And you can see in this trial, there's a twitch at time 0 after that. So that's the stimulus recruiting additional moment on top of this submaximal voluntary contraction. And we measure the stimulated twitch or the superimposed twitch moment as the peak to peak. And we do this for various effort levels. And this represents a muscle without an activation deficit. And then we can plot all of those trials So the x-axis here is the elbow extensor moment itself relative to that twitch moment that's recorded with superimposed stimulus. And we can use linear regression. I'm trying to advance my slide. There we go. Do that for multiple trials and use linear regression to calculate a predicted moment. And relative to that subject's maximum voluntary moment that was recorded, if there's a lack of an activation deficit, or in other words, the person can fully activate that muscle, then the predicted moment and the voluntary moment are quite similar. And therefore, when we compute the ratio of the maximum voluntary moment to the predicted moment, we get a ratio of about 1. So here's some example data of a muscle with an activation deficit. So the primary difference here is that even on top of the maximum voluntary contraction, the electrical stimulus is able to elicit an additional superimposed moment, such that ultimately the predicted moment exceeds the maximum voluntary moment generated by the subject. And so then when we compute that voluntary activation ratio, we get a ratio that's less than 1, indicating a deficit in voluntary activation. Okay, so we tested all of the arms with regard to voluntary activation, and these were our results. So here I'm comparing the biceps transfer to the deltoid transfer. Biceps is shown in red relative to the deltoid in blue. And this is across the 3 functional postures in the horizontal plane, overhead reach, and pressure relief. So what we found was in the overhead reach and pressure relief conditions, voluntary activation of the biceps was greater than that of the triceps, or sorry, of the deltoid to triceps tendon transfer. And we also saw posture-related differences in the ability to activate the deltoid transfer. The results with regard to elbow extension maximum voluntary contractions. Again, the biceps transfer is shown in red relative to the deltoid. And here we're looking at the maximum voluntary elbow extension moments that could be generated. For each individual, we recorded 3 MVCs in each of the postures. And the primary result here is that in all 3 postures, the biceps transfer generated larger elbow extension moments relative to the deltoid transfer. We also assessed cortical motor excitability in each of the 3 postures. So we did so using transcranial magnetic stimulation. So I'll briefly explain what that is, in case you're not familiar. It's a type of non-invasive brain stimulation. So when a current is passed through an electrical wire, a magnetic field is generated. And when that magnetic field passes through a conductor, like the brain in this case, an electrical current is generated. And with coil design and placement of that coil, we can target the electrical current in the brain to stimulate cortical neurons that ultimately project to innervate muscle. And at the muscle level, we use an EMG sensor to measure that signal. And that signal, we calculate what we call the peak-to-peak motor evoked potential, or MEP, which we'll commonly refer to. So we tested the individuals with biceps transfer using single pulse TMS at 120% of the resting motor threshold. And again, we recorded MEPs in each posture. We found a positive relationship between MEPs, or our measure of cortical motor excitability, and strength, as measured by the maximum elbow extensor moments in the individuals with biceps transfer. So here's the data showing that positive relationship. Unfortunately, we weren't able to do the same analysis in the subjects with deltoid transfer. It happened to be that the majority of our deltoid transfer subjects also had implanted neuroprostheses, so that was a safety concern with regard to the use of TMS in that subgroup. So the conclusions and significance of this study, primarily were that the arms with biceps to triceps transfer could activate the muscle better and also generated greater elbow extensor moments. The difference in the neural control augmented the greater force generating capacity of the biceps. And even with complete voluntary activation, the deltoid transfer arms would still generate smaller elbow extensor moments. So the significance of this was that we found both neural and mechanical factors that contribute to the large variability in elbow extension strength outcomes after tendon transfer. As all research does, this led to a new research question. And that research question was, can we improve motor relearning and or strength after tendon transfer in tetraplegia? So as a quick recap of what I just told you, we did see deficits in voluntary activation in the arms with deltoid transfer, but also in both groups relative to non-impaired healthy subjects, the elbow extensor moments that they generated were still quite low, so limiting in terms of use of the elbow extensor. So our new research question brings us to point 2 on the presentation roadmap, which is non-invasive brain stimulation. So why? Well, there's a body of evidence that's developing suggesting that priming cortical excitability with repetitive non-invasive brain stimulation prior to training can enhance training effects. For example, in patients post-stroke, repetitive TMS, or a form of repetitive TMS known as intermittent theta burst stimulation, can increase corticomotor excitability. 2 weeks of ITBS prime therapy improved upper limb function at the chronic stage of stroke for at least 1 month post-intervention, and therapy alone did not improve function. Here's a nice simple depiction of theta burst stimulation. Simply put, the stimulating coil delivers short 50 Hertz bursts of stimulation at 5 times per second. A series of 10 bursts are separated by 8 seconds, and these bursts mimic the theta rhythms in the brain and thus termed the theta burst stimulation. Here's a quick video of what theta burst stimulation actually looks like in our lab. You'll probably notice the nature video that the subject's watching, and we do show nature videos during our experiments to control for cognition. So let's quickly pull, oh, that didn't play. All right, just in case you're not familiar with TMS or theta burst stimulation, that's what it looks like. As our field, our current best understanding of the mechanisms is that ITBS enhances cortical synaptic efficacy, resulting in long-term potentiation of neurons. The intermittent pulses sustain the calcium influx to postsynaptic neurons. And these mechanisms, again, are our current best understanding, but they continue to be explored through computational models and also through animal models and human experiments. So our study objective was to assess the effect of intermittent theta burst stimulation on the excitability of the corticomotor pathway projecting to the biceps, in 3 groups. One group being non-impaired individuals, the second group being individuals with cervical spinal cord injury, and a third group being individuals with cervical spinal cord injury and tendon transfer. So the novel aspects of this work are that we targeted the biceps muscle. The research prior to this study all targeted the hand, or primarily. This is the first study using ITBS targeting the biceps. Also, we had participants come participate in 3 repeated sessions. And we included spinal cord injury subjects in our protocol, and the study was also sham controlled. Our hypothesis was that in each subject group, biceps corticomotor excitability would increase from baseline after the active ITBS and remain unchanged after sham ITBS. The participants to date, this is a pilot study, so our target recruitment is 10 of each group. We have completed 10 non-impaired individuals. So far, we've collected data in 7 individuals with cervical spinal cord injury and 1 individual with a biceps transfer. Before we deliver ITBS, we established the stimulation parameters. That involves recording the maximal M wave. So that's needed for normalization purposes. That represents the maximum signal we can get from the EMG sensor on the muscle. So in order to compare motor evoked potentials from participant to participant, or even with the same participant across days, we use this maximal M wave of the recorded from the biceps to normalize that signal. We also established the stimulus location, evoking the largest peak-to-peak motor evoked potential at the minimum stimulator intensity. And we determined the resting and active motor thresholds. And thereby subsequent MEPs are recorded at 120% of the resting motor threshold, whereas the intensity of the active ITBS is delivered at 80% of the active motor threshold. So here's a schematic showing the ITBS protocol that we did in this study. So again, I just talked about the parameters we established at the beginning. So determining the RMT, AMT, and recording baseline motor evoked potentials. And then we always started with sham. Sham is delivered through a sham coil that makes the same noise as the active coil. And after the ITBS is delivered, we record MEPs at 10-minute increments up to 30 minutes following the stimulation. Following the sham measures, we then use active ITBS. So we switch the coil unbeknownst to the subject and deliver active stimulation. Each participant completed 3 sessions of this protocol, and each session was separated by at least 3 days. Because it's fun just to look at data sometimes. Here's some example motor evoked potentials in a subject with spinal cord injury, just so you get a visual picture of like, what are these outcomes we're looking at? So here I show motor evoked potential amplitude in microvolts at baseline. We're plotting multiple trials on top of each other, and then the black is the average of those trials, just to give you a sense of what our motor evoked potentials look like after or before and after the stimulation. We used a linear mixed effects model to determine the effect of active or sham stimulation on the normalized motor evoked potential. So that's what the NMEP represents here in this figure. So I'm plotting the average normalized motor evoked potential at baseline and then 10, 20, and 30 minutes after ITBS. And this is data from the non-impaired subjects. The active measures are shown in pink and the sham measures are shown in black. And the take-home message here is in the title. We did not see a change in the normalized motor evoked potentials after ITBS relative to baseline. And now I'm presenting results in our spinal cord injured subjects, and we've had 7 subjects to date. And we have seen in those subjects that active ITBS does increase normalized motor evoked potentials relative to baseline at time points 10 and 30 minutes after stimulation. We also found an interaction between time and coil on normalized motor evoked potentials. I'm not going to spend any time on this table, but I did want to, it's important to note that within across sessions, we did find that the resting motor threshold, active motor threshold, and baseline normalized motor evoked potentials were not significantly different. So the major takeaways of this pilot study and our future work are that the effect of ITBS targeted to the biceps does differ between non-impaired and spinal cord injured individuals. In non-impaired individuals, we did not see a group-wide effect, whereas in the individuals with spinal cord injury, there was evidence for increased corticomotor excitability, therefore suggesting that ITBS induced the expected long-term potentiation-like effects to increase corticomotor excitability of the biceps. I didn't present this data, but we also found relationships between the active motor threshold to resting motor threshold ratio with motor evoked potentials in both the non-impaired and spinal cord injured subjects. So this ratio may serve as a predictive measure for both groups, and something we'll investigate further. In terms of future work, we plan to investigate the effects of ITBS on transferred muscles, again, to address that question of can intermittent theta burst stimulation improve motor relearning? This is also a nice time to point out that we're just at this stage in the research establishing baseline changes in the neurophysiology. Ultimately, the goal is to pair non-invasive brain stimulation with a therapy. Other future work are to investigate the variable responses of ITBS using computational brain models. So we found a large variability in our motor evoked potentials, which is consistent with the literature. And so there does seem to be a need to use modeling to understand the variability, but also potentially we need to use different stimulation parameters. The protocol we used was established for targeting hand muscles, so it's quite possible a different protocol would be needed for targeting more proximal muscle. And as similar to what I was just talking about, does ITBS paired with training, which is the ultimate goal, does that enhance training outcomes? That's something that needs to be explored in the future. So we are collaborating with the VCU Biomagnetics Lab to develop individualized computational brain models. This is because brain neuroanatomy likely has an effect on the induced electric fields due to ITBS. Thus, it provides a means to understand between individual variability. And the goal then is to determine how individual neuroanatomy affects induced electric fields. So we're using diffusion tensor imaging to generate models of individual fiber tracks, and then using Sim4Life software to induce or simulate the effects of that induced electric field due to the TMS, or transcranial magnetic stimulation. Other non-invasive brain stimulation related projects we have going on in our lab right now are, one question we had was, can we assess voluntary activation deficits in cortical drive after spinal cord injury? So if you recall, our method to measure voluntary activation in the tendon transfer subjects involved peripheral stimulation, and that can give us information about the net deficits and the pathway projecting to the muscle. But we can apply the stimulus using TMS to the motor cortex in order to detect deficits in cortical drive as well. This is a technique that's been developed and tested in non-impaired individuals, and so we're establishing how well that technique actually works in individuals with spinal cord injury. We're also conducting a study to determine the effect of a stimulus waveform on motor evoked potentials, and also the effect of low-cost neuronavigation on motor evoked potential variability. By low-cost neuronavigation, I refer to low-cost motion capture and calibration tools that can track the head and coil during an experiment to provide feedback to the researcher. So I did sneak into roadmap area 3 here without giving you a warning. With the limited time left, I've got a little bit of time. I just wanted to introduce musculoskeletal modeling and simulation projects related to upper limb function in spinal cord injury. Musculoskeletal models and dynamic simulations of human movement can inform upper limb rehabilitation after spinal cord injury. In our previous work, we used modeling and simulation to estimate tendon forces developed by the rotator cuff muscles during weight relief lifting. Weight relief lifting is needed to relieve pressure in order to prevent pressure ulcers. We were specifically interested in whether the restored elbow extension via tendon transfer had an effect on shoulder forces generated during this movement. The significance being to prevent the development of shoulder pain. So unfortunately, individuals with tetraplegia who rely on their arms for all the activities of daily living commonly develop shoulder pain and then eventually lose use of their upper limbs. So research in shoulder pain is really needed. Very briefly, an attempt to describe forward dynamic simulation. The simulation is driven by neural control signals to muscle, which are subject to muscle tendon dynamics, where we can represent the relationships between muscle length with muscle force and also muscle contraction velocity with muscle force production. These muscle tendon dynamics are represented in a musculoskeletal model. The model is governed by the dynamic equations of motion. And what is unknown originally is this neural control input. So how do we establish what the neural control input is? Particularly, we can't rely exclusively on EMG, as there's more muscles in the model than EMG sensors or muscles that we can actually record a good signal from. Thus, we rely on dynamic optimization to generate simulations. The goal of the optimization process is to determine muscle excitations that minimize the difference in experimental and simulated joint kinematics and kinetics. So we actually record the biomechanics in a human subject performing weight relief. We record kinematics and also kinetics, being forces at the hand rim. And we just submit an initial guess of what the muscle excitations are driving that movement, and then rely on an optimization routine to figure out what is the appropriate muscle excitations to generate the same kinematics and kinetics that we saw in the human subjects. So that's the iterative process that is used to generate simulations. Once we have simulations that are reproducing what we observed experimentally, we can analyze them. And here again, we were interested in the rotator cuff tendon forces, because we know that the rotator cuff muscles are subject to injury during this movement, and we don't have a clear picture of what those forces are sustained. So in this figure here, I'm presenting results from, in dark gray, tendon force during the lift in an individual with tetraplegia without tendon transfer, and then an individual with tetraplegia who had biceps transfer. So we were looking at the two different modes of elbow extension. And looking at figure A, you can see we did find a different distribution of tendon forces based on this mode of elbow extension. That was seen in shoulder muscles such as the supraspinatus and subscapularis, as well as in the elbow extensor muscles, as one would expect, considering the mode of elbow extension was different. And we also found a difference in the elbow flexors, again expected because one individual had a biceps transfer, so in this case the biceps is an elbow extensor. But looking at the B portion of this figure, which presents tendon force normalized by the maximum isometric tendon force, regardless of the mode of elbow extension, the tendon forces were quite high. So that leads to our bullet point here, that in both modes of elbow extension, normalized tendon forces were high relative to previous work that was done in non-impaired subjects. So ultimately, the stress on the rotator cuff muscles is higher than even we initially thought. We found that biceps transfer can provide lifting ability, but does not substantially reduce rotator cuff tendon forces. We're currently starting a similar project to study wheelchair propulsion in manual wheelchair users with spinal cord injury across the lifespan. By estimating shoulder forces, we hope to gain an understanding regarding who and who does not develop shoulder pain. So our goal is to quantify rotator cuff tendon forces and also glenohumeral contact forces in spinal cord injury wheelchair users. Again, the modeling and simulation is needed since we can't directly measure these forces in human subjects. So ideally, human subjects research will return in a safe manner soon so we can actually start working on that project. So far, we've obtained funding and IRB approval, and now we await the ability to recruit subjects. Okay, well, again, many thanks for the opportunity to present today. I'd like to acknowledge my lab and also my collaborators of work presented here, and also our sources. And with that said, I'm happy to answer any questions.
Dr. Peterson, thank you so much for your excellent presentation. I'm really impressed with the data that you presented today, and it will definitely open more room with collaboration with you and your lab in the future. I have not seen any questions coming my way on the chat area, but I'm expecting that people may ask few questions. But until then, I have a couple of questions that I so to start with. The first one, I've seen that you have focused primarily in your tendon transfer studies in doing the isometric mode of action, and I wonder if you have considered doing the isokinetic or just to see the force velocity relationship between the muscle after tendon transfer compared to normal or healthy population?
Yeah, so in terms of voluntary activation, that was a first step to see, all right, in a static condition, how well can they activate the muscle? So I guess why, I'm going to throw a question back at you, sorry, but why would you be interested in the force velocity relationship?
Yeah, just like to determine the mode of action, very similar to normal function. They usually, when we do either transfer from wheelchair, stuff like this, two portions of the modes happen, either starting with isometric, then you move on to the isokinetic portion. And I understand you may be interested primarily in determining the force deficit in the muscle, but also I wonder if you would have seen or established force velocity relationship with this happening.
Yeah, so the study where we tested the tendon transfer in weight relief lifting was our first attempt to have a dynamic assessment of the use of the tendon transfer in an activity of daily living. But there's definitely a lot of room for research with regard to tendon transfer. With that said, it is a hard population to recruit because they are, unfortunately, these surgeries are underutilized, and that makes the logistics of doing research a little difficult. And I think there's a lot of interesting questions one could ask about nerve transfers and tendon transfers, but that is a primary problem in doing a lot of research in this area.
Okay. I'll open it for other attendee to ask questions if anybody. Okay. In my second question, I've seen that you have you were talking about initially the burst stimuli or TMS, using the burst stimuli, and with regard that this could facilitate the motor deficit in the muscle. And my question, does this is also can be applied for person with complete injury or only for incomplete injury?
Our understanding right now is that this works best for individuals with incomplete injuries. So it can promote, we've seen in animal models primarily, that brain stimulation can promote sprouting of axons around the area of the lesion. But in terms of forming new connections, we don't see evidence of that. So I guess the short answer is, so far, incomplete spinal cord injury is the target population for non-invasive brain stimulation.
Do you have a problem recruiting people with tendon transfer? How prevalent is this population in the entire tetraplegia? Like, how often does someone with tetraplegia usually undergo a tendon transfer operation?
Shoot, I just was looking at it. I want to say, okay, so I believe that the statistic is about 70% are eligible, but in reality, only about 10% of individuals choose to undergo tendon transfer. And then the reasons for that have been studied, and they're various, but examples of reasons are not wanting to undergo a surgery. Also, whether it's covered by insurance, lots of factors. I'm trying to, other factors that prevent, hope for a cure, right? So it's a surgery that would be hard to switch back the other way. But with that said, those who do undergo the surgery have great functional benefits and are happy with their outcomes.
And my last question, do you think that there is a move in the field from doing tendon transfer to do nerve transfer, or this is two separate things? They cannot one lead to another?
An individual might be a candidate for either nerve transfer or tendon transfer. Nerve transfers are relatively new development, so tendon transfers have been done for about 40 years now, whereas nerve transfers have become more, or it's an area of research, I'd say, within the past 10 years. So there haven't been as many of them done, and we don't quite know the outcomes following nerve transfer and how that compares to tendon transfer. But it's essentially the same principle, whether you're physically moving a muscle or you're transferring a nerve. The idea is to reinnervate a previously paralyzed muscle.
Okay, well, with that said, I would like to thank you very much and for your talk and for your topic, because this is really a very interesting topic, and we would like, or we would hope in the future that you would accept our invitation again to just like to share with you some of your current and recent findings in this area. And on behalf of ACRM and the FES and Technology Task Force, thank you so much and have a great rest of the day.
Great, thank you.
Thanks, everybody.